Hello guys, just wanted to cover diverticulosis or diverticulitis. Same disease, just different levels of acuity. So what is diverticulosis? So if you look here at the colon, we have the ascending, transverse, descending, and the sigmoid. In the United States and Western worlds, they're little sacs of pouches that develop from pressure within the colon. And in Americans, it typically occurs in this S-shaped loop of the colon called the sigmoid. But it can occur in the descending colon and ascending colon, but that is definitely more rare. Asian countries, it can occur in the ascending colon more commonly than the sigmoid, like in America. The way I look at it is it's sacs that are developing from pressure within the bowels and commonly will present with a left lower quadrant pain if it's becoming an acute problem, which is what we call diverticulitis, itis, inflammation. Osis is just the process of the disease. So the problem with developing an osis is that it can become an itis and create an abscess in the bowels, become infected, and can even bleed within the colon, so you'll get bleeding out the rectum, or perforate, which causes a peritonitis, which is just inflammation and bowels spilling out into the abdomen, causing essentially septic shock, and with the result, if not treated, death. So the most common thing in the literature for the cause of this is high pressure and slow bowels. So if you have slow bowel movement or slow motility of the bowels, things tend to back up and expand. You can think of it like walls. Things are pushing on those muscle walls in the colon, causing high pressure, and that muscle layer will actually develop these little caps as it tries to hold the pressure back. And the problem is the colon has lots of blood flow, lots of vessels that line that muscle layer. It's essentially muscle, 3 layers of it, and if it ruptures, can bleed extensively, and obviously all that bowel, that stool will spill into the gut and cause sepsis. So in the Western countries, the data shows that the most implicated thing as the cause of diverticulosis is low fiber. And the reason low fiber is implicated is it slows the bowels. So having a healthy digestive system includes regular bowel movements, soft fibrous stool that is not compact and hard like rocks. In America, the way I remember this is about 50% of the population will develop the osis, the diverticulosis, by the age of 50. Not everybody will go on to develop the itis part, the diverticulitis, but when they do, a lot of times they're very sick. We do see them in family care in the early stages if they're aware of their disease process. The low fiber essentially also changes the gut microflora, and there's a lot of information coming out these days on the microflora, its relationship with inflammation in the gut and a healthy gut. So low fiber diets have lower rates of healthy bacteria that normally live in our gut and do play a role in that, but also for the motility, to move things forward, to have regular bowel movements. Interestingly, certain medications are implicated in increasing diverticulosis rates, including NSAIDs, opiates, and steroids. Now, the NSAIDs actually affect the way the mucosa, so the muscle layer, can affect that. Just like we can develop gastric bleeding from NSAIDs, it's the blocking of the prostaglandins. If you look at the pathway of how NSAIDs work, that increases the risk of the muscle wall having issues. Opiates naturally, as part of their anticholinergic side effect, stop the bowels from moving. And so if somebody continues to eat and their bowels are not moving, you can imagine the pressure that the colon has to deal with. Now, naturally, the colon muscle can relax to deal with it, but everything in our body has limits to what it can withstand. People on chronic corticosteroids are at risk. We're not talking about a single round of steroids for another condition. We're talking about people with autoimmune condition or transplants that need chronic steroids. And steroids in themselves are catabolic, meaning they break down muscle tissue And our colon's made out of muscle, so you can see that there could be a link with that with chronic steroid use. It just causes a host of problems in the body, but certain individuals can't live without them. So that's just something to consider too when you're treating a patient that comes in with lower left quadrant pain. The purpose of the sigmoid, just to talk about that, the rectal area, the rectum itself, is to pull the water to concentrate the stool. And you can see why that could be easily affected if things are not going well and we have constipation. It's going to put a lot of pressure on that sigmoid rectal area, and especially if we're chronically constipated and we have hard stools or we just can't go. So the thing is with diverticulosis, it's asymptomatic until it becomes itis, diverticulitis. And at that point, we get infection, we get abscesses, we get the perforations, we'll have the vital system changes, vital sign changes, that lower left quadrant, typical of America. So those are things to keep in mind. Now here's some pictures. This is a colonoscopy here, the sigmoid area, and you can see these holes here. These are not normal. These are all diverticulosis forming these outpouchings from high pressure. The rest of the colon here, you can see, doesn't have those. And so these are affected areas that, if impacted or pushed too far, can either rupture or cause abscesses and infection in there. The picture to the left is more just showing the anatomy of this. The muscle layer here, these little outpouchings, and you can see how it gets pressed and you form these little outpouchings, which, because this is a scope, you can't see that. You can see them on CT, and I'll show you a picture. But you can see how all these arteries that surround all that highly vascularized muscle could rupture and bleed into the sigmoid and out the rectum. Or if bacteria gets in here and it kind of gets trapped in there, assuming how that happens. There's not a lot of data on that, but the bacteria can flourish and cause a localized infection, and we get the symptoms of diverticulitis. So how do we teach our patients, how do we prevent and treat the diverticulosis before it becomes an itis and acute? And there's another picture of some of those outpouchings of the osis. You can see the highly vascularized area of that muscle mucosa within the pouch. So like we talked about, the number one risk factor is a low fiber diet. So having high fiber in the diet can help. We want to keep the bowels moving, whatever we need to do to have regular bowel movements to reduce some of that pressure within the sigmoid. There is some information on how fiber helps grow beneficial bacteria within the colon. And so there is a link with healthy prebiotic, probiotic dietary, either through the diet, through the high fiber, soluble fiber, insoluble fiber, to create a good microenvironment to protect. It reduces inflammation as one of the ways that it can protect from developing these diverticuli in the gut. We want to teach our patients to avoid NSAIDs, not just for the kidneys and the risk of gastric bleeding, but also it injures the gut and causes weakness in the muscles. Like we talked about earlier, opioids, is slow gut motility. Now, obviously, there's a place in medicine for both of these medication classes. Obesity is also highly linked to the development of diverticulosis. So teaching our patients to lose weight, to lose the belly. All that fat around the midsection puts pressure on the organs. Among other problems like liver disease, can the fatty liver disease. But when we look at the data, when scientists are looking at the data, they're seeing that there's a huge relationship between obesity, diabetes, and diverticuli development. So that's something to think. Now, something else mentioned and up to date is jogging. So that cardiovascular exercise, people who do that are found to have lower rates of diverticulosis. So once again, this is a preventative medicine and treatment once development of osis, the form of the non-inflammatory form of diverticulosis, is lifestyle, healthy eating, losing weight, correcting the diabetes, avoiding medications unless absolutely necessary, and cardiovascular exercise incorporated multiple times a week into your lifestyle. So how do we treat it when the osis becomes the itis? This is when you're going to see your patients. They're going to come in. Now, there's two forms of this. There's the inpatient hospitalization, which is necessary in certain cases, and then there's the treatment outpatient through family practice, which is where most of my experience comes from. I do have acute care experience and some training in that. So I have seen this come in completely septic, completely ruptured, peritonitis, bleeding through the rectum, requiring surgical intervention, and the patient septic in the ICU, borderline death because of this. So we're going to see the rectal bleeding rarely. So it may be as little as 10% of patients with the diverticulitis could develop the rectal bleeding. And it is on the differential for anybody with acute rectal bleeding, a diverticulitis, basically rupture of a vessel and bleeding inside the colon. So almost all patients are going to have abdominal pain. So this is an infection, this is an abscess, this is a rupture, it's going to hurt. Many patients will develop a low-grade fever, and so taking vital signs is absolutely necessary. Even in family practice, if we get more than one vital sign abnormal, so whether we're tachycardic, we have high heart rate, whether we're hypotensive or hypertensive, plus that low-grade fever, they really should be treated inpatient and not outpatient. So the other thing that we can do is, if we have the ability in family practice, some offices have the ability to run a CBC rapidly, and if you see leukocytosis, that lower left quadrant pain, plus a fever, we need to be aggressive. So one thing that can help differentiate the different types of itis from other conditions is not related to the bowel, the sigmoid, is a CT IV contrast. Now in family practice, this is not something you can really do. It's not necessarily a walk-in thing to Radiology Limited and get a CT scan quickly and then see the patient again and make a decision to send them to the hospital or not. So if the symptoms appear moderate to severe, always inpatient is safer, just in case they need IV medications. And if they already have a mild perforation that needs treatment rapidly, may need surgery, we obviously can't do that in family practice. Okay. So the other principle to keep in mind is, how old is my patient? Older people, usually greater than 65, 70, have more gut issues than a younger person that comes in their 40s and 50s. So the risk of having perforation or a substantially bad outcome if they develop sepsis is so much higher in the older population. So we need to our trigger for treating inpatient should be a higher threshold if our patient is older. If you're going to treat this outpatient, which I've treated it in multiple different ways, but the two main things that we're going to do is we're going to have the patient stop eating, we're going to have them a fluid-only diet, allow the bowels to rest, and write for antibiotics. Now I have had patients successfully treat this with diet restriction, fluids only, with an antibiotic script in hand that I asked them to fill, and then because they were so mild, to wait the 2 days to see if things get better. If it didn't, I told them to essentially start the antibiotics. Now, you can still send your patient to get scanned, ultrasound, if you're going to treat outpatient. Obviously, CT is preferred over ultrasound, but a lot of clinicians will order right lower quadrant ultrasound, even though it's not nearly as sensitive to picking up diverticulitis. Now, the antibiotics that typically get chosen are the Cipro with metronidazole. If the patient has a reason not to take Cipro, like they have some kidney issues, which you need to be acutely aware of, especially in the older population, then Bactrim plus the metronidazole. And the thinking with this is Cipro in the Bactrim can cover gram-negative bacteria, which is what we tend to harbor in the colon. And the metronidazole covers for anaerobic bacteria, which we tend to collect also in the colon. So it's a dual medication administration to cover the main bacteria within the colon. And we're assuming that with diverticulitis, with the mild fever and the left lower quadrant pain, that we have an abscess forming. And the main implicated bacteria in that are what we carry in the colon, the gram-negative and the anaerobic. So if you treat outpatient, always caveat, tell your patient if they're not better in 48 to 72 hours, go inpatient, get looked at, get scanned, and they may need IV antibiotics. If you treat outpatient and the patient gets better, great. In 6 weeks, you want to follow up with them, especially if this is a reoccurring problem, and refer to gastroenterology to get a colonoscopy, take a look to see what's going on. Now, in outpatient setting, a lot of times you're not going to be able to diagnose the first timer diverticulitis right away without a scan. You can assume that it is a diverticulitis if they've had a diagnosis of diverticulosis or been previously hospitalized, and they kind of learn what that symptom, that early symptom feels like. I've had multiple patients come in with multiple cases of hospitalized diverticulitis and understood how those symptoms start to present early, and we'd immediately get them started on antibiotic and fluids only, and they tend to do fine. If you have any questions, leave me a comment. I appreciate it.